Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
This activity includes discussion of therapeutic products that have not been approved by the U.S. Food and Drug Administration, off-label uses of approved products, or data that were presented in abstract form. These data should be considered preliminary until published in a peer-reviewed journal. Readers should verify all information and data before treating patients or employing any therapies described in this or any educational activity. A qualified healthcare professional should be consulted before using any therapeutic product discussed herein.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Johnson & Johnson.
Journeys is a Medscape live conference event, providing attendees with an innovative and immersive learning experience. The audience begins by viewing a series of videos where patients detail their personal journeys of living with their condition. Next, our key opinion leaders engage directly with the audience, gathering people's reactions, experiences, and questions. Finally, those experts take the stage to discuss each patient's journey, present the latest in care, and address questions from the audience. Now, we're bringing you this event, wherever you are, so you can join the journey. For this recap, it's the patient voice in MDD, why and when to augment therapy, from the Psychiatry Update 2026 conference in Chicago, Illinois.
One of the patients was talking a lot about residual anxiety as a symptom. What do you like to do for residual anxiety?
Anxiety, you guys know this, it occurs, at least 70% of the time in patients with MDD. Others may be a little bit less, but it's very, very common. Or put it in another perspective, I find it less common that somebody just has depressive symptoms with no anxiety. And I think one of the things that I tell my patients is that a lot of times when you treat them with an antidepressant, it may help with their anxiety as well. But as far as a benzodiazepine, I know that there are certain offices in my area that actually have a sign right when you enter, we do not prescribe benzodiazepines. So I think there's a lot of pros and cons as far as what to do for anxiety for our patients, but I certainly do think that a lot of times when you treat them for their MDD, their anxiety may lessen as well. And the second thing is that a lot of times when you give them an augmenting agent, that can also be helpful for their anxiety as well.
Yeah, to your point, so if the anxiety is a manifestation of the underlying illness, you might want to try to treat that underlying illness more aggressively. If your patient has really bad pneumonia, should you maybe think about the underlying antibiotic?
Right.
Some of our agents have known anxiolytic properties. Some of the atypical antipsychotics, second-generation drugs, aripiprazole, quetiapine, lumateperone, all have been shown to reduce anxiety in the setting of depression. So I might think about, is an anxiolytic augmenting agent, if not primary agent, in the picture. Want to add anything?
Totally agree. What was often a point of discussion was, well, these people had mostly monoaminergic treatments, and they're not even on medication anymore because most likely the side effects were not justified by the efficacy. So I think augmentation is really something we need to talk about, not only for anxiety, but also for depression.
So that brings us to a few additional questions about, okay, so you can augment, but there's so many things you could augment with.
People ask, what is approved and has data?
Or both.
Or both, even better.
or good data. So for example, there's questions, how about adjunctive bupropion? A very interesting meta-analysis by Dr. Hensler, which said, believe it or not, bupropion has a fairly small effect size as an augmentor to monoaminergic antidepressants. You could certainly do it, but you get a bigger effect size with a drug like mirtazapine or potentially also with some atypical antipsychotics. So as we think about from the questions here about which adjunctive antipsychotics, many, not all, but many have FDA indications, to your point about what's approved. Dr. Carell, how do you think about which adjunctive atypical antipsychotic might deliver the best effect in TRD?
Well, TRD is different than difficult to treat depression.
In difficult to treat depression.
Okay. Well, because there's obviously only olanzapine fluoxetine approved as an atypical for TRD. The other agents didn't do these trials.
True.
But the data that will come out in a couple of weeks that we're both co-authors on really suggests that lumateperone is better. Aripiprazole, brexpiprazole, cariprazine, and quetiapine. And then I would look also at side effects. Quetiapine helps maybe anxiety, but boy, it can cause sedation, dry mouth, and cardiometabolic side effects. We looked at even 25 to 50 milligrams in Denmark, and even at that dose for sleep, you will increase metabolic syndrome rates and cardiometabolic risk. So that's certainly for me something I would give very much later. And then the data for cariprazine, although it's prescribed a lot, are not as robust, I think, as for aripiprazole and lumateperone. And brexpiprazole has also some data, but the remission and response rates were not that high.
And cariprazine didn't really have a linear dose response.
Not at all.
Lower doses work better, especially in anxiety.
Yeah.
Maybe.
If I can add also, at least in primary care, there's a tremendous amount of hesitation, though, to add an atypical antipsychotic, a tremendous hesitation. And it comes out primarily because all the older ones, we have had such bad luck when we treat our patients with metabolic changes, with weight gain, glucose elevations, sedation, extrapyramidal effects, that sort of stuff. So there's a lot of hesitation using them. Wouldn't you gentlemen also say that with the newer atypical psychotropics, those side effects are less, so maybe we shouldn't have as much hesitation? Would you agree with that?
The data support what you just said.
Yeah.
So not to dwell on any single molecule, however, there are 6-month data with adjunctive lumateperone in major depression. The average weight change was, I believe, negative 0.35 pounds or something like that. So yes, if you can find a metabolically neutral agent, all the better. And if it works, that's much more of a home run too.
I would say when it comes to the hardest symptoms of my depression, it would definitely be anhedonia. Not being able to really feel any pleasure and not being able to feel pain either. And so this can certainly be a really, really big trigger for me. Hopelessness is another very, very difficult symptom of my depression. And both anhedonia and hopelessness have triggered suicidality in the past.
Caroline used the word anhedonia in describing her depression, and something that's shorthand to mean I can't feel pleasure. She actually, I think in her video, described this rather nicely. Didn't she say, I can feel neither depression nor pain? I've always thought of anhedonia as like the 13th cranial nerve. You say to a patient, here's something that's inherently pleasurable, not your job, which you don't like, not your marriage, which you're not sure about, not this, but music, food, something that should elicit a pleasure response, and if it doesn't, your nucleus accumbens is broke, as far as I'm concerned, and medicines can help try to fix that. So what do you all want to give Caroline if she is indeed anhedonic? Anything in particular come to mind?
The first thing I would say, by the way, is I don't know of any patient that comes to me and says I have anhedonia.
Someone gave her that language, probably.
Yeah, but we do. They also don't volunteer that I'm not enjoying things. At least to me, they don't volunteer that. You kind of have to ask them. And some of the questions that I ask is, are you really not enjoying things that normally you would enjoy? Just like Joe said, things that normally should be enjoyable, like eating and being with your family, being with your friends, going to the ballpark, things that used to give you pleasure and enjoyment. Are you having problems with that?
I feel like a huge part of my identity, both for myself and externally to others, is my love of nature, including being outside as much as possible when I'm not working. My anhedonia has really impacted this. I find myself feeling really non-committal about like hiking or other outdoor plans, second guessing if my plans are worth the effort.
Now, as far as what medication to use for that, from what I recall, there are some medications in clinical trials that do look at anhedonia, but those are ad hoc analyses, if I'm not mistaken, right?
Post hoc analysis.
Post hoc, excuse me.
But I don't think that's a problem, because it's fair to explore the hypothesis that in someone with major depressive disorder who has prominent anhedonic features, you can look back and say, how did people in the post hoc analysis fare with the hypothesis, I wonder if the drug didn't work as well in the anhedonic patients. So there are data with
vortioxetine and venlafaxine, but the problem there is it's a 5-item derived, MADRS-derived anhedonia scale, and 2 of them are apparent sadness and reported sadness. So it's a little bit of an overlap with depression. So we had a lot of discussion about Caroline, because that's where I was standing, and people were talking, well, what about moving outside of the monoaminergic treatments? Esketamine, dextromethorphan, bupropion, wouldn't that give maybe a different push and have some glutamatergic drug? Lumateperon also, because of that D1-related push. So I think we need to broaden the scope.
Indeed, so the data with dextromethorphan, bupropion do show both improvement in overall depression symptoms better with dextromethorphan bupropion than with placebo. So that is to say the presence of anhedonia was not a negative predictor of response. And if Caroline is indeed anhedonic, you might say this is potentially a negative predictor of outcome, but a drug like dextromethorphan bupropion would be a little more robust. I think the data with lumateperone also would suggest robustness. And so it's a fair point to ask, is not just can you feel things better, but also if you have that anhedonic melancholic type of depression, it might steer you towards certain medicines.
But would we want better studies with either the SHAPS for consumatory anhedonia, or also the DERS where we have anticipatory anhedonia, because these are different domains that we don't always ask about and haven't been measured. So I think novel generation trials should have these scales also in them to inform our drug selection.
So Dr. Carell is a researcher, and as a researcher, he's telling you about the Snaith-Hamilton anhedonia scale, which is a much more specific way of tapping anhedonic features. And if you're a researcher, by all means, familiarize yourself with it. But on a clinical level, it may just be worth asking a lot of qualitative questions about what are the things that you normally enjoy. And I think this is especially hard in depression, because you're trying to sift apart people who are saying, I don't like my environment, as opposed to I can't perceive pleasure from the things that are normally pleasurable. So as a clinician, I think you can make that very vivid for the patient. What are the things that normally give you pleasure? It may be activities, hobbies, friends, basic kinds of things. And if that's diminished, that's an anhedonic subtype, and it has to factor into your thinking.
Most people that I've known throughout my life don't know that I struggle with depression. And I think it's because I've learned to cope with it and to kind of hide it and internalize it. But I try not to let it have as much of an impact on my life as I know it could. Things don't come as natural to me as they used to in terms of enjoying the various aspects of life and friendship and family and communication. I think that's been more of my struggle, to find the enjoyment in everyday things, whether it be hobbies or personal interactions. Those are things I force myself to do because I know that's what I should be doing.
A few people asked about at what point should esketamine or ketamine be brought into the picture. I guess you could say by definition, anyone who has not responded to 2 adequate trials of MDD needs to be considered a candidate for intranasal esketamine. Heck, it's FDA approved for that. Beyond that, anything else that would make you think?
Suicidality, it came also up with Caroline because she had that as a secondary effect of anhedonia, because there are data that esketamine can treat people, particularly with MDD and suicide.
In the label, treats depression in people with suicidal ideation. That's not to say it's going to take away your suicidal ideation. We didn't know that, but we can say, you have the subtype of depression for which suicidal ideation is present. That's not everybody, but it's substantial, and robust benefits there. Any other thoughts about esketamine?
In my practice, it's perfectly common to see patients that don't reach remission after one medication. And one of the things that I tell my patients is that there's at least a 50-50 chance that the medicine I'm going to put you on, as much as I tinker with it, isn't going to get you to remission, which is what has to be our goal. That's the very important thing. It's like, because I do primary care, I always give them the analogy. I don't want to just get your A1C from 9 to 8 or your blood pressure a little bit better. I want to get you a lot better to the point where you're completely normal. So one of the things that is interesting is all the patients, except for one, both of them have been on just one medication, and they've never been on an augmenting medication. And in fact, Henry is on 2 medications, but one of them is bupropion, and Joe already told you it's not a very good augmenting medicine. So what I say as far as esketamine goes, it's a good medication to add, but I would think that one of the things that you want to tell your patients, at least what I do, is a lot of times you're going to need a second medication augmenting as opposed to go to esketamine. So I usually will use an augmenting agent first before I think about going to esketamine.
Paul, someone asked about sleep as a residual symptom of depression. Could you say a word or two about that?
Sleep is such an important facet. You know, when patients come to my office and we do complete physicals and that sort of stuff, I always ask about sleep. It's one of the 4 things that you need to do very well in life in order to be healthy. We'll talk about the other 3 if we have time. But sleep is such an important factor. And we know if you have a residual symptom of poor sleep, insomnia, you're much more likely to have a recrudescence of your depression and a worsening of your depression. So that's a very important point. So treating insomnia is a very important thing. Oftentimes I will treat the insomnia at the same time that I'm treating depression. And a lot of times you don't have to treat them for a long period of time, maybe several weeks to a month or so, but some do need to have chronic insomnia treatment. But insomnia treatment is very good. We have data on that.
How do you do it?
Well, it depends on what kind of insomnia they have, whether they have sleep onset insomnia, whether they have sleep maintenance insomnia, or late stage insomnia. And there are some good benzodiazepine receptor agonists, which are good. There are also the orexin receptor antagonists, which are good. Some of the benzodiazepine receptor agonists, they do have data on depression. For example, S-zopiclone does have data on depression. You know, patients being treated with an SSRI and S-zopiclone, they have better remission and response rates if they have depression and insomnia than treating them with an SSRI alone. So I do like to treat the insomnia at the same time if they in fact have it, thinking that they're probably going to get better compared to those that don't take an insomnia medicine.
Anything about orexin 1 versus 2? We have the slide up.
Yeah, that's a very good question. I'm not really sure. I don't know that much about seltorexan. Maybe you do, Joe. But as far as insomnia with depression, with the 3 on the left, the Darado, Lembo, and Suvo, I don't know that they have any data with depression, but I do know that they're pretty good as far as getting patients to sleep better as far as insomnia is concerned.
So single orexin receptor antagonists, or SORAs as opposed to DORAs, seltorexant being in development example, is a molecule that modulates that particular type 2 orexin, thank you, receptor. And the orexin pathway is involved in wakefulness, right? In narcolepsy, you don't make enough orexin, and so you like this. And so orexin antagonists, in addition to having a sleep-promoting effect, at least one of them that's in development may show signs of leveraging more depression symptoms, perhaps in part, if I can get in through your depression circuitry and the wakefulness pathway, maybe that would have some benefit. So it's an exciting molecule that's, I think, on the horizon. Who here wanted to give anybody lithium? 900% likely you're less prone to make a suicide attempt on lithium than off lithium. Anybody wonder if that fellow who's been sick since he was 13 years old might have bipolar disorder and nobody asked? You know, don't ask, don't tell. WNL, we never looked, right? So if you don't ask those questions, I agree with the people who had said at the very outset that if you're not asking enough of the right pertinent questions, you're going to feel like you're spinning your wheels. And a lot of these patients almost gave this sense of like a randomness. I tried this, without really delving into the more particular details. Some questions about trauma histories that were brought up, and that's a tough one. There isn't really.
So that's important. There are data that trauma history really seems to impair SSRI response, but that doesn't seem to be true when you have glutamatergic and NMDA receptor modulation. So for esketamine and even for dextromethorphan bupropion, that doesn't seem to be a determining factor. So that's really important to, if that is in the picture and SSRIs don't work, to maybe step it up into a different system.
If I can also add, I think in all the cases here, and as I was going around, I saw a lot of questions coming up from you that you wanted more information, not just about trauma and about family history, but also a lot of you said, you know, what about a mood disorder questionnaire? I mean, have these people have manic or hypomanic episodes? Maybe the reason why they're not getting better is because we're dealing with bipolar depression and not just treatment-resistant of depression, or MDD that just requires an augmenting agent. So I'm very glad to see, by the way, that a lot of you had questions. You wanted more information in order to make a better diagnosis. What are we dealing with here? It's so critical, making the diagnosis. When students come to my office, I tell them, the most important thing that you can do here is make the right diagnosis. To get that, you need all the information that you need to make that diagnosis.
How many of you are using measurement-based care in your practices?
What is that? How would you define that?
Measurement-based care. So you need a rating scale of some kind to quantify the symptoms that you're looking for. Our colleagues elsewhere in medicine have things like scales that you step on and it measures your weight, or sphygmomanometers. We don't have blood pressure cuffs and thermometers, but kind of like the way the pain doctors will ask you on a scale from 0 to 10, how's your pain? Or the way my eye doctor says, is this blurrier or sharper? We can ask questions about the specific symptoms, and a measurement like the PHQ-9, the Montgomery-Åsberg Depression Scale, the QIDS, even the Clinical Global Impression Scale, or if you like, even just the real simple question, are you better, the same, or worse?
I think it'd be helpful for providers to ask more specific questions about specific symptoms instead of just going by a depression scale. And part of that conversation that I think would be really helpful is prioritizing what symptoms are of most concern to the patient, and then trying to be thoughtful about the right medication based on that prioritization, instead of just running through a list of the most typical medications and then switching them, kind of like whack-a-mole.
Because at the end of a trial, you'd like to be able to say, are you better or not? If you're not better, why continue a medicine that's not working? Where there is this concept of deprescribing a drug for lack of efficacy, or if the side effects outweigh the benefits. But if you and the patient in a shared decision-making model can both agree that things are better and the benefits outweigh the risks, you're onto something.
I believe that the patient should definitely be an advocate for themselves and to always share their experiences with their healthcare provider every step of the way. It's really important to note that the healthcare provider isn't going to be with the patient at every single moment. And there's a lot of information that can be lost. And so I feel that it's important for healthcare providers to regularly check in with their patients. I think that the combination of both the efforts of the patient and the healthcare provider could really amount to something really special and making progress in the patient's treatment.
And I don't think any of these patients really gave a clear sense that they felt involved in a shared decision-making process.
My relationship with physicians has been pretty one-sided. I've already done my research on all these different medications, and I read a lot of clinical results as well as patient testimony, what their experiences were with particular medications. And I say, this is what I want to try. And 9 times out of 10 over the years, they've always been like, okay, let's give it a go. So use your expertise and what you've learned and what your experience has been, and get to know me as a patient, get to know what my symptoms are, what my struggles are, and you provide a solution.
In primary care, one of the things that we always do, we have our patients coming in for annual checkups. We always do screeners for depression, because it's interesting with the PHQ-9. Because it's very interesting. A lot of people don't actually volunteer symptoms of depression, and you have to actually ask that. And then we follow them along with how well they're doing with their depression with a PHQ-9, which you can bill for.
Oh my God, what a concept. I do an assessment and I can bill for that. Yeah.
Yes, you can. You can't get paid by everybody, but at least you can bill for it.
It's also nice to be able to say to a patient things like, you're 47.2% better, and that's what this means. And it gives them benchmarks. It's almost like, makes tangible something that might otherwise feel very nebulous or intangible. And I think that's part of what we want to do, is to give patients a sense of agency and empowerment, and we're tracking particular symptoms. And by the way, you might have improvement in some symptoms, but not others. So as you're deciding about keeping and augmenting versus switching, if your suicidal thinking is better, if your sleep is better, I might retain something in the regimen. And that's another factor we might consider with augmentation. Last word, Dr. Crow.
Symptoms are only the start for something else that patients and families really want, and that's functioning. So there are no skills in pills. We need to get them better, but then reintegrate patients into life, find out what's important for them, have behavioral activation, maybe psychotherapy, have families, friends come back into the picture. So symptomatology is just the start. If we stay there, patients also check out because they do not feel appreciated.
Indeed. All right. The last word you hear from Dr. Hill. Thank you all for joining. I hope this exercise was useful, interesting, and informative.
Thank you for watching this program. We hope you found it interesting. We'll see you on the next journey.